So we are now live, just admitting everyone.
Wow.
May I want to see talk? What? May I want to see Dada? Daddy?
You can see.
Listen.
It's not very exciting. It's not like TV. It's studies
Aaron,
work.
turn your mic off. Has to be a gosh fellow, doesn't it?
Brilliant. Thank you very much, everyone, for joining us. Really excited to introduce another journal club of the virtual Interventional Radiology Journal Club that's been going on since January. My name is Jim. I'm a trainee in Leeds, and I'm really privileged to be joined by a true panel of experts. And I'd like to introduce the session, which is on Paediatric Interventional Radiology and Renovascular hypertension. And this month, we've been fortunate to work collaboratively with the Society of Paediatric Interventional Radiology. And I'd like to introduce my co-chair, Dr. Rush Tuning, who is an attending pediatric interventional radiologist at Boston Children's Hospital. He's also a tutor at Harvard Medical School. So over to you, Dr. Tuning, to introduce the panel and the session. Thank you very much.
Thank you, Jim. It's a real privilege and an honor for SPIR to be co-hosting this event with the BSIRT and IRJ. And thank you, Jim, publicly for all the work that you've put in coordinating this. I think we have a good program today. We're going to be looking at renovascular hypertension in children. We have an amazing panel, including the two authors of the paper that we'll be reviewing. We have one other expert who does a lot of work in this area, and I hope to have a second join us, and hopefully he'll be able to log in. So as I mentioned, just a real privilege to be involved in this. We picked this topic because there's good overlap between renovascular hypertension in adults and in children, but there are some key differences, and we'll get into some of those in a bit. But I felt like it would be a good touch point to kind of bring these two patient populations and worlds together. So let me, without further ado, introduce our panel members and then introduce our fellow trainee who will be presenting the article. So first up is Anne-Marie Cahill, one of our paper's authors. She did her medical training at the University College Galway in Ireland, and then did some internal medicine training there as well. And then in Dublin. She earned her master's in radiological sciences from the University College in Dublin, and then did a fellowship in general pediatrics at British Columbia Children's Hospital before going to Children's Hospital of Pittsburgh for a PEDS IR fellowship. She is now in Philadelphia at Children's Hospital of Philadelphia at CHOP, where she's an attending PEDS IR doc and section chief in IR. She is also a board member for SPIR and currently serving as president-elect. So welcome to Dr. Cahill. The other paper author is Prem Patel, who has lost 20 kilos recently, cut his hair, and looks different to all of us. He did his medical training at St. Bartholomew's and Royal London Hospital School of Medicine and Dentistry. Did some training in surgery and pediatric surgery in London before pursuing clinical radiology in Southampton. He did a pediatric IR fellowship at Sick Kids in Toronto, and now is at Great Ormond Street in London, where he's a consultant pediatric interventional radiologist. His role in SPIR last year, he was the junior representative to the board, which is the role that I'm serving in now, and he's laid a great foundation for that. So welcome to Dr. Patel. Next up, we have Dr. Gulrez Chowdhury, who happens to be right across the hall from me. He did his medical training at University in Edinburgh, and then did pediatrics at the Royal Victoria Infirmary and Freeman Hospital in Newcastle. He then pursued radiology at the University of Birmingham, followed by pediatric radiology and pediatric IR fellowships at Sick Kids in Toronto. We're developing a Toronto theme, and hopefully our Toronto colleague will be joining us shortly. He came to Boston Children's thereafter, where he's a pediatric IR attending, and he also serves as fellowship director here. He's on multiple committees for the SIR and the ABR, as well as being a board member for SPIR. I'll go ahead and introduce Joao Amaral in case he joins us. He did his medical school and radiology residency in his home of Paraná in Brazil. And then he also went to Sick Kids in Toronto for pediatric radiology and interventional radiology. He now is there as an attending and section chief for IR, and he currently serves as a board member for SPIR. And he's in the role of treasurer this year for SPIR. You may know it as SPIR or SPIR, depending on where you're located, but that's what I mean when I say SPIR. So that's our esteemed panel. Thank you, panelists, for joining us. We look forward to your lively discussion after the article is presented. Presenting our article today is one of our trainees, our fellow Rakesh, who goes by Rocky Ahuja. He did his medical school in Mumbai, India, followed by residency in general surgery. He then went to USC in Los Angeles, followed by Einstein in Philadelphia for further training. And that's when he transitioned into radiology and earned an IRDR certificate there. He's currently our PEDS IR, one of our PEDS IR fellows here in Boston. In the past several years, he's been on numerous committees and leadership positions in the SIR resident and fellows section. And he's a core member now of our SPIR social media team. So thank you, Rocky, for presenting this paper. And
I just said it, but I understand.
Thank you, Rush, for the kind introduction, and thank you for this wonderful opportunity. I have a great opportunity to present the review article on renovascular hypertension. I'm just going to start my screen share. And I'm fortunate enough to have two of the authors also here as the panelists who were responsible for getting this paper to limelight. So Dr. Premal Amrish Kumar Patel and Dr. Anne-Marie Cahill were the co-authors on this renovascular hypertension in children paper, which came out in CVIR in this year. This is the link to it if anybody wants to refer. And I would highly recommend reading this if you are anywhere involved in treating renovascular hypertension, because it covers pretty much every single aspect you need to know about. And by that, I mean, this is what we are going to cover: background, associated diseases, diagnosis, management, and conclusion. The blood pressure above the 95th percentile for age, sex, and height is usually what's considered renovascular definition of hypertension. And usually it's an incidental finding. Although as soon as we diagnose this and manage this, this can significantly impact the long-term CVS events and renal impairment. And renovascular hypertension itself is responsible for 5 to 25% of hypertension in children, and is potentially treatable to the point that it may even be cured. The blood pressure elevation, which the mechanism behind this is that there is alteration in the renin-angiotensin mechanism, which is secondary to the lesion, which reduces blood flow to the part or all of one or both kidneys. The renal artery stenosis, especially the renovascular hypertension, has several associations, some of which are listed here, and we won't be able to cover all of them in a very comprehensive manner, but we'll only cover like the salient aspects which are relevant to our topic. The renal artery stenosis and mid-aortic syndrome, they have an association with fibromuscular dysplasia, Williams, neurofibromatosis, type 1, tuberous sclerosis, and the multiple other vascular disease, which includes Takayasu's, Kawasaki, polyarthritis nodosa, even can be as a result of post-radiation and then post-transplant. Some of the salient aspects of some of diseases that we talked about is FMD, especially the non-syndromic ones, are thought to be the most common cause of renovascular hypertension. Takayasu's is vasculitis involving the large arteries, which mainly affects the young women, but it can also affect children. NF1 is another most common cause for renal artery stenosis in children in Western countries. And these are little publicized as together combo, but they should be something that is necessary for us to be aware about. Williams syndrome is another one, which is a multi-system disorder with cardiovascular abnormalities, and it results from elastin deficiency. It can cause renal artery stenosis and significant morbidity and mortality. As far as the renal artery stenosis and mid-aortic syndrome, is concerned, this can be isolated or together and could be uni or bilateral. And they're reported to be bilateral in about 24 to 78% of pediatric series cases. And here's the reference to it. And then could be focal arterial stenosis, can also involve multifocal, and diffuse stenosis when there's likely extra renal disease or syndromes. Concomitant the renal artery stenosis is seen about 60% of the children with mid-aortic syndrome. So renovascular hypertension can be diagnosed by various modalities. The easiest one is the ultrasound, which we all know about. It can show you the stenosis waveform, which is parvus et tardus waveform, and you can also directly visualize the stenosis. There's pathologic age-dependent flow parameters, which the peak systolic velocity of about 180 or 200, and acceleration time of more than 80 milliseconds, renal artery to aortic flow velocity of more than 3, and difference in resistive index of more than 0.05. These are all sort of like pretty specific and sensitive to renal artery stenosis, so something that should a clinician should be aware about. A length of more than 1 centimeter is an indirect sign of renal artery stenosis, and I'm talking about the renal length on each side. Ultrasound can even detect other abnormalities, which include pheochromocytoma and neuroblastoma, which could cause hypertension as well. Next up is CTA and MRA. The concept remains the same. Yes, there are different modalities, but they can visualize the stenosis or even the presence of collateral vessels. It's limited as far as the distal small vessel evaluation is concerned, which is similar to ultrasound, and again have a very high sensitivity and specificity as listed here. Angiography should be done only if there is a high probability of RVH, although it is considered gold standard in establishing the diagnosis. The possibilities when the angiography can be considered is when patient has a normal BMI, no family history, elevated renin levels, and hypertension requiring multiple medications. The diagnosis can be bumped up to angiography directly. I mean, ultrasound, yes, but after that, angiography can be the intervention that can be done because it's also therapeutic. Lewis et al. Study, they found 28% of vascular lesions in children with hypertension were only detected by angiography. And then abnormality is seen in about 40% of the patients where have poor blood pressure control on multiple medications. Here we see one of the beautiful image, and one of the things that I wanted to mention, this article definitely has some of the beautiful images, and one of them is this. There you can see the renal artery stenosis and the axial contrast enhanced CT angiogram, which demonstrates this left renal artery stenosis, which can be seen on this MIP image, confirmed on subsequent rotational angiography and angioplasty by the demonstration of this waist of the angioplasty balloon. Another modality of diagnosis could be intravascular imaging like IVUS or OCT, which is optical coherence tomography, can show you live, although they have not been validated in RVH, however, can help identify the early arterial wall changes, vessel wall thickness, degree of stenosis, aneurysmal walls, and and the results of angioplasty and or stenting. IVUS has been used before, which could be helpful in appropriate stent sizing, as well as identifying acute complications such as dissection and stent malposition. This is one of the images from the article again, where you see there's significant narrowing, severe right renal artery origin stenosis with mural thickening. This is the mural thickening part, which is consistent with FMD, and post angioplasty IVUS image with significantly improved flow and vessel diameter, which you can see here, 2.6, 3.6. Although it's just a millimeter, but that is what pretty much makes the huge difference in kids. Contrast enhanced ultrasound, it can play a role in evaluating renal perfusion pre and post angioplasty. However, it also is used as a modality for a follow-up, which could be much more helpful than actually pre-procedure. This can be helpful to identify any parenchymal perfusion defects, especially during intervention. Another beautiful image, single frame from the contrast enhanced ultrasound, which was taken immediately after the microsphere injection. This shows the cortical, the first one shows immediately pre-right renal artery angioplasty with reduced cortical perfusion to the right kidney. And now you can see there's so much more robust improvement in overall perfusion. This is something that new I learned from this article, perfusion imaging, which there is a significant growing interest in the color-coded quantitative digital subtraction angiography, which is also called as perfusion imaging. Currently, it is commercially available angiography quantification post-processing software such as Singi, iFlow, and AngioViz, but they are limited by variability in flow, vessel size, and amount of contrast injection and frame rate. I would love to know more about them eventually. These are some of the, again, images from the QDSA, images of pre and post angioplasty angiography with post-processing using Singo iFlow from Siemens, non-parametric imaging, the time to peak opacification, demonstrating using color coding. Again, this is the color coding, which green signifies a significantly improved perfusion as compared to the blue, which demonstrates improved time to renal perfusion post right renal accessory stenosis angioplasty. Here is the angioplasty. Here is the stenosis. Here is the angioplasty, post angioplasty, significantly improved perfusion. Next up is RVR, which is renal vein Renin sampling. It's done to lateralize and localize the ischemic focus, which could be causing hypertension, and help direct the selective treatment. Samples are taken from intrarenal IVC, each renal vein, and from upper intrapole and lower pole intrarenal tributaries on each side. And if there is a renin ratio of more than 1.5 between main renal veins, that's considered significant. Moving up next up to the management. The mainstay in the non-invasive and non-interventional treatments still stay as antihypertensives, and ACE inhibitors and angiotensin receptor blockers are in fact contraindicated until the critical main renal artery stenosis or bilateral renal artery disease is excluded because of their blockage of renin-angiotensin mechanism. When the vascular disease is more further out into the arcuate branches, the ACE inhibitors and ARBs can be used to control the blood pressure. Majority of the kids actually do not end up achieving normalization of BP despite multiple medications. Angioplasty apparently is the mainstay of the treatment, which is indicated when the blood pressure is inadequately controlled or associated with significant adverse effects. The goal of the treatment is to restore renal perfusion and reduction in polypharmacy, which helps in temporizing hypertension. Renal artery proximal to the stenosis is used as a guide for the sizing because of the post-stenotic dilatation that cannot be reliable the other side. So pre-stenosis is what is really important. And high pressure balloons can be used for resistant stenosis. There is little evidence with the drug-coated balloons, but in cases of CTO, they can be recanalized again just by angioplasty. Stenting is a very controversial topic in kids, but if it's required in renovascular hypertension, it has been shown beneficial. But although we're going to talk more about stenting in a couple of slides from now. Cutting balloon angioplasty can again be used if the high pressure balloon itself is not enough, or the conventional angioplasty is not enough, or if there's a long stenotic segments. The increased risk of dissection and renal artery aneurysm is very high, especially when you're using the cutting balloon. And the one thing to understand about them is you cannot use the diameter, which is more than the normal size of the vessel. It doesn't matter whatever it looks like. It has to be aware. One has to be aware about the size of the vessel normal. And IVUS can be used as a guidance, which could be pretty helpful. Stenting, as we said, it's slightly a controversial topic, especially in kids. And because when kids grow, stents themselves can act as a site of stenosis. So stent placement may be useful in severe or recurrent lesions. However, surgical options can be considered before placing the stent unless it's an emergent requirement because of the complications which have happened of the intervention. And we're going to talk more about that. Ethanol embolization is again something sounded like pretty amazing. You can use the superselective ethanol embolization to treat the diseased segmental arteries, which cannot be treated by angioplasty, and open reconstructive surgery is impossible. Ethanol causes severe irreversible endothelial injury and hence causes infarction of this renin-producing ischemic parenchyma. It's sort of considered as a nephron-sparing function, so you do not have to do the surgery. Coil embolization should be completely avoided because coils, as we all know, just are responsible for decreasing the pressure head, and the rest of the, there's always going to be recruitment of collateral supply. Outcomes of endovascular treatment is between 18 to 60% of the patients are completely cured. Presence of aneurysm, collateral vessels, and mid-aortic narrowing do not predict the end result. Angioplasty results in restenosis about 17 to 41% of the times, and repeat angioplasty can always be performed without increased risk. The reported time intervals between first and second procedures, it varies from 0.4 to 60 months, which is a wide variation, but it has helped in controlling the morbidity and mortality in all that time. In children, tearing, flap formation, or dissection are the most common mechanisms of dilatation after balloon angioplasty. Therefore, it all makes sense that we should do a repeat angioplasty with help vessels to remodel to a larger size. A little bit about the aortic management. In children with mid-aortic syndrome, hypertension is often pretty refractory to medical management, even though if the kid is on polypharmacy. In these patients, following the angioplasty of the aorta and renal arteries and plus minus stenting, the change in blood pressure is reported to be higher in children with MAS and renal artery stenosis compared to those with isolated disease of the renal arteries. Surgical interventions in mid-aortic syndrome have been shown to require less reintervention than endovascular interventions, but they come with their own complications and morbidities, which we are going to talk about. And adopting a primary endovascular treatment strategy does require that there are repeat interventions may be required in future. Known complications can be from 0 to 43%. Contrast-induced nephropathy, arterial spasm, dissection, pseudoaneurysm, delayed perforation. All these are known. Distal emboli can also cause perfusion defects, especially after post-angioplasty or in situ thrombosis from the prolonged guide wire in the segmental vessels. Local dissection often is the name of the game when you're using the cutting balloon. And then endovascular treatment, the blood pressure may be labile, so therefore kids who have a known cerebrovascular disease, they should be assessed prior to the intervention, especially with the head and neck vessels before you even intervene. Because if there is a blood pressure is labile, they can end up with pretty severe consequences, including stroke. This is one of the pictures of the complication, which shows non-flow limiting dissection. Right here, angiography, and then it demonstrates the loosened dissection flap. Which just again, this one is another one which shows distal embolic phenomena after the angioplasty with focal segmental renal artery occlusion. Here again, we see left renal artery, which shows early bifurcation. There is a pseudoaneurysm with after the angioplasty of the tight long stenosis, and then that pseudoaneurysm was which at the site of the angioplasty, it was embolized with coils, and this is 2 months post-embolization, and it still is nice and patent. In surgery, as far as the surgery is concerned, there was a huge study which was done, 47 angioplasty studies and 23 surgery studies, which showed cure rate is slightly higher in surgery than the angioplasty, which is 54 versus 36%. However, it comes at its own cost of 2.5 times higher major complication rate than just the intervention itself. There is a similar, the data is not that much available in pediatric population, just for the fact that the disease itself is quite rare, and surgery is used infrequently as the primary treatment, given the established safety and success of endovascular interventions. In conclusion, the current literature supports an endovascular approach for investigation and management, and the most data is derived from retrospective or observational studies. It's quite difficult to develop clear guidelines for diagnosis and management. due to wide range of reported outcomes and paucity of extensive information. Currently, there is a consensus agreement that children with RVH should be managed at centers with expertise in these areas, and especially when you have multidisciplinary care, which significantly improves the outcomes involving the pediatric nephrologist, vascular surgeons, and pediatric interventional radiology team. That's it.
Excellent presentation, Rocky. Thank you so much. That's a lot of content in a very short amount of time. So thank you for setting the stage for what hopefully will be a lively discussion. Jim will be looking through the chat feature of this meeting. If you have questions, please type them into the chat box, and Jim will be compiling those and then posing them to the panel. So while you type those questions, let me get the panel started with a few questions that are prepared in advance. So one of the things that this article kind of hints at and goes into a little detail is the differences between treating adults with renovascular hypertension and treating children. So panelists, could you please expand on that a little bit? And then as a follow-up, what tips and tricks would you offer to folks who are more familiar with treating adult patients, but want to treat or have the opportunity to treat children? Are you able to unmute? There we go. I see Prem has unmuted. Anne-Marie and Gulrez, there we go. And Joao has joined us now. Hi, Joao.
Hi. Go on, Anne-Marie, you were saying something.
I said Rush will have to point fingers at us. We're too polite. We're not all just.
Well, I'll kick off then.
Kick off, yeah, because we're all just. Yeah.
But it'd be nice to hear Gulrez and Joao's opinion, because mine and Anne-Marie's opinion is there on paper. But in terms of the differences between adult and children, well, first thing to say is I need to put my hand up and say I don't treat adults, so it's difficult for me to tell you the exact differences. But I think on principles, the differences are that when we are doing an angioplasty, or the disease process is that of FMD primarily, and therefore the process of angioplasty is one in which you are going to cause some intimal damage and rely on the process of remodeling through recovery. And I think it's implied in the paper, therefore you have to accept that you will be coming back a number of times. And I think the key thing, again, implied in the paper and what we touched on, is that you have to be resistant to picking up a stent, because it doesn't look as nice as you want it to at the end of your procedure. I mean, I think those are the key differences. And then there's the whole bunch of technical things which are to do with getting access, and the fact that sometimes the renal arteries in children come up at a more acute angle, and you may need different approaches. But that all gets very much more technical. But I'd like to hear what Gulrez and Joao think.
No, I agree. I mean, I think the disease processes are different. We have a combination of FMD. You also have congenital conditions that were touched upon, such as NF1 and Williams, also that's particularly associated with mid-aortic syndrome. The other thing to think about, as you mentioned, was in terms of the actual approach to in both imaging as well as intervention. And this may be touched upon later, but certainly in our center, we do go away. We tend not to use MRA as our primary non-diagnostic imaging, non-interventional imaging. We find CTA to be much more accurate in terms of diagnosis. The other thing to consider, and this will be interesting to see what everyone thinks here, is would you go straight to angiography in some cases, or do you always obtain a non-interventional diagnostic modality?
Hi, Rush. João here. I thank you very much, and I want to congratulate Anne-Marie and Prem, because what the the article is great. It's excellent. It's a great summary of what is hypertension in children. I think it's very similar to what we do here in or what we profess here, where the biggest difference, and similar to Prem, I don't treat adults, but you have to be a little bit more cautious with children in the sense of being so aggressive to put a stent or thinking that you're going to solve the problem. You solve for a short span, but you always have to think that a 70-year-old patient that you solve the problem for 10 years is very different, the lifespan of this patient, than a child that's 5 years old, where you're going to put a stent and you're going to solve the problem for a while, but 5 or 10 years later, it will be a stenosis to be dealt surgically, not even interventionally. So this is important to remember, and also remember restenosis and in-stent restenosis. So that's one of the comments that I was going to make. Similar to Goray's, I prefer CTA. I think the resolution of the CTA is still better than the MRAs. I know that there are excellent MRA qualities and all that. One of the challenges is any stenosis gives you a little bit of a swirling effect in the MR, and you sometimes, even with the best contrast and all that, you may lose a little bit or overestimate the stenosis. There was a question, and sorry if I'm listing a couple of things, about the importance of doing imaging. I find that cross-sectional imaging has always helped me. If you look at the statistics, and people used to think that the stenosis is predominantly inside the kidney. In fact, it's in the first or in the main artery or in the second order branch. And these are vessels that most of the times can be detected on good CTA. Well done with proper timing and good bolus. And nowadays in children, you can do this, especially with the new CTAs with multi-planar reconstruction. So I like to have a CTA to plan my intervention and to know what I'm going to use. I always use, for me, the smallest devices that I can put, the better. It's less problematic, it's less complications for the child. The vessels are smaller. So if I have a 4 French system that allows me to put a balloon catheter and that I can dilate 3, 4, 5 millimeters, I would use that. Even if I don't have a guiding catheter like an RDC catheter that would sit in the artery, I would rather have more exchanges and taking a little bit longer, because dealing with a pseudoaneurysm after the procedure is not so fun, rather than using a smaller device. And the CTA I like, but if I do not find, if there is a suspicion, if the child has a hypertension, and I do not find anything on the ultrasound or on the CTA, I think it's warranted to do an angiogram. The reason is 25% of children, or hypertension in children, or let me rephrase it, between 5 and 25%, depending on the statistics, is related to avascular diseases, renovascular disease. So I think it's worth doing the angiogram to exclude, because if you find a reason that you can treat, avoiding putting a child for their whole life on hypertensive medications, I think it's a big deal, and it's worth the risk of doing an angiogram. I think it's worth in that situation. And if you do an angiogram, a good angiogram, with the child anesthetized, with respiratory, holding respirations, with an anesthetist that works together with you, you get great images, and then you at least exclude, or you can remove that as a cause of hypertension. And you have to remember that 75% or 75 to 90% will still be idiopathic or have another reason to be, but for a child to be hypertensive. Sorry, Rush, I'll stop here.
Oh, no need to apologize. That was very good. I think for the audience, maybe some of you who aren't used to the pediatric world, to hear experts recommending CT is quite unusual. we tend to avoid radiation at all costs, but this is one of the rare entities where CT is actually very helpful and worth the radiation risk, even in children, because it just is so much better than MR for the reasons that Dr. Amaral mentioned. You guys have done a very good job of anticipating some of my questions. Sorry, Dr. Cahill, you were going to say something.
Yeah, maybe you were going to ask me this, but the caveat with CT is beyond that first segmental artery, the resolution drops significantly unless you have a higher dose. And I will say one of our fellows was the first to publish actual percentages this past year in Peds Radiology on 2 blinded readers, one medium, one younger than I am, but I would say medium level, and one junior, blinded, looking at the CTs and the angios without having information on either up front. And the pickup rate intrarenally, even in retrospect, for intrarenal stenoses, and we have 15% of those in our large series we're just publishing now, finishing up like 91 lesions, was 15%. And the pickup rate on CT was 14%. So I would say if the patient has a normal BMI, which was significant in our study for the risk of actual abnormality or not, and has been shown before, if you have no family history, even if you're on one medication, you should have a renal angio. And we have 15% of our patients have an intrarenal stenosis that we have beyond the first order that we've treated. Not insignificant. So I would say CTA for planning, absolutely. Do you need to do the arm? Do you need to go in through the leg? What size balloons? May you use the cutting balloon or not? That has to be planned for, because that's not a 4 French sheath. That's at least that's a 5. All of that is very good for CTA, but beyond the hilum and that first segmental artery, I would not trust it, which I think is what's different in children.
No, that's actually, you did anticipate my question is, you know, in this paper, and I guess it's backed up by your recent data.
Yeah.
You know, the study you quoted by Lewis et al. Said that about a quarter of lesions were only detected by angiography. And I was going to ask the other panelists, has that been your experience in practice as well, where you have a similar percentage that you only pick up by going to angio? And what's your threshold for going to angio? I guess Joao and Anne-Marie have already answered that, but Prem and Golriz, have you had similar experiences?
Well, I think that the Lewis paper is Anne-Marie's cohort.
That's an earlier paper, yeah. Yeah.
And in that paper, the other paper that we talk about is the Troutman paper, which is our cohort, which looks slightly differently at imaging. But we, and I guess like many of your centres are slightly strange in that our referrals come from far and wide, and often they come with some degree of imaging, and it might not be something that we would have elected to do. So often they come with an MR, or they may come with an ACT that was perhaps not done, as Joao say, perfectly as we would want. And so basically we have an unwritten policy, and we accept what we're given in terms of that imaging. So we don't repeat CTs, we don't repeat MRIs. So if we see something on it, we see something on it. We know ultimately that you're only going to exclude or include things by doing an angiogram, so we go straight to angio. On those few children where they come directly to us with no cross-sectional imaging, we actually take them to angio without cross-sectional imaging.
Yeah, I think that's probably something that's changed over the last 15 years in my practice, that I actually ended up doing more diagnostic angiogram than I originally used to be honest. Because, you know, we generally tend to veer away from doing purely diagnostic interventional procedures, but there is significant evidence that, you know, you can identify disease that you could potentially treat. Yeah, I mean, the question always has been that, okay, you can identify, you know, more disease with angiography, but does it make any difference in terms of intervention? And I think you certainly within past the first order, there is treatable disease that I have identified only on angiography. So if we get to a position where we have a high suspicion for a renal arterial lesion, but we cannot identify anything even on cross-sectional imaging, then we generally will go on to perform angiography.
The other thing I'd say is it's also a prognostication, because if you find intrarenal disease you can't treat, and you've lots of collaterals, at least you know the patient's not going to come off medication. It may or may not be a good ethanol location. In my 18 years, I have not found a good ethanol candidate personally. It would knock out too much normal kidney, but at least you know. Because I think, and that's one of the big points, that you can prognosticate it may be very deep disease that's parenchymal, and it could be bilateral. 30% of our disease was bilateral in the paper that Finn wrote back in 2011. So not insignificant, you know.
I think it also guides the other decision making because, well, there's two things, I guess, is that to know the distribution and extent of intrarenal disease, it guides the decision making with regards particularly to ACE inhibitors.
Yeah.
Because when nephrology are able to then make that decision about putting them on an ACE, they know they're going to take, you know, a portion of the kidney, effectively medically nephrectomize some of that patient. And then the other decision making that it helps with is even when you've got proximal disease, to know about the distribution and extent of distal disease helps you to know whether it's worth pursuing a surgical option in terms of autotransplant. There's no point autotransplanting a child with osteal disease if there is, you know, widespread distal disease, because you are not going to cure hypertension.
I know Jim is still collecting questions, so if you have questions, please type them in the chat function. If you would indulge me, one more question before I let Jim reflect. I don't want anyone to feel put on the spot, but renal angiography, renal artery interventions carry some of a higher risk profile than a lot of the procedures that we do in the pediatric IR world. What are some complications that you have experienced in your practice? How have you managed those? And part of the issue is, how do you manage the families, both expectations beforehand and walking them through the complications? I know that's a very loaded question, but seems relevant to the topic.
I might just start with the cutting balloon, because that's something that I'm using more and more, and we have over 35 lesions that we have used the cutting balloon on now that will be soon published. So families really want their kids to come off medication. You know, some of these kids are on 2 and 3 medications with lots of side effects, lots of poor compliance. We have to be very clear that we may use the cutting balloon, and they tend to really buy into that. It isn't a very nice feeling to do a lesion to dilate it even to 1 millimeter higher and see no result from that. And personally, that has been my experience without the cutting balloon in NF and in some other resistant stenoses. We had a pseudoaneurysm, which you've seen in the paper with Prem, that we had to coil with neurocoils. I had a frank rupture there recently, which was very successfully contained with balloon insufflation for 10 minutes. And it will go into our next paper, because it looks like a perfectly normal renal artery after it had been a tight stenosis. But you do have to have a certain level of tolerance for risk, because there are risks, but the yield is amazing once you get to that point of tolerance. So you will have a rupture occasionally, and you will need to have a balloon insufflation for about 10 minutes. I don't stop the heparin because you don't want the rest of the kidney to thrombose. And we have had some distal embolic phenomena at the site of angioplasty. So again, it's a risk benefit. I would say by the time patients come to us, they really want something done. Even if they're on 1 medication, the families are very anxious to have the patient off medication. And certainly 2 or 3 is challenging. I don't know how other people feel, but.
Yeah, no, I agree. What I find very useful is to have these discussions as part of an interdisciplinary team, because you know, if your surgeon or your nephrologist is advising your patient or your parents that this is the way to go, that endovascular intervention is the safest approach, even though it carries some risks, I find that parents tend to buy into it a lot more. I mean, obviously, we've all seen complications from this. I personally have seen leaks, dissections, Yeah, if they're flow limiting, you can just angioplasty, and I haven't had anything that's required surgery since then. And also, partial thrombosis and distal thromboembolic phenomenon, not that unusual. But the other thing to think about here is, going back to interdisciplinary care, is that if there is a lesion with a high risk of potential complications, is to actually coordinate it with your vascular surgeons. Yeah, so you can have a more informed decision rather than trying to come up with something when something has gone wrong.
And that's a very important thing. Gulrace, you've got a mid-aortic syndrome program at Boston Children's. We do not have an on-site vascular surgeon at CHOP, but we have a very close collaboration, not physically, intellectually, with the Michigan surgeons, John Stanley and Dawn Coleman, and we have monthly nephrology rounds now where the surgeons will be on for their opinion when needed. So that's another thing to think about now in the era of having a virtual platform. You can have people have multidisciplinary meetings and show multiple renal artery stenosis cases and have a surgeon on among ourselves as well, not even just within the institution. It's very important that they give you permission to proceed, inverted commas. Yeah.
I was going to say, maybe our practice slightly different, maybe similar to Gulrace's, that we treat quite a lot of mid-aortic syndrome. So those are the ones that worry me the most, especially when you're doing them on a small child, because we have a vascular surgeon on standby, not physically around always, but they very comfortingly tell me, oh, if you rupture a renal artery, we can sort it out. But we're just here for moral support when it comes to the aorta. And we have had one aorta that not ruptured, but we've got a big dissection. It lost all flow distally, but we managed to salvage that. So I think dissection's a big problem. And as we spoke about before, the aim of the game is to make some endothelial damage, but it's that fine balance of what's enough, what can you leave, what can't you leave.
So Prem, I'm just to ask you, you're still doing aortic angioplasty for mid-aortic syndrome?
Yes.
Okay. Yeah. I don't know about the others, but in our philosophy is to get them to a point where they get their aortic bypass as teenagers, but just to keep the kidneys open, not to do angioplasty at that point, prior to that. But I don't know how.
We've been doing the aortic, so tends to only be suprarenal aortic angioplasty, obviously, to perfuse the kidneys. We do treat some infrarenal aortas so we've had occlusions that we reopened, but only to serve as future access. So we keep them small.
And how about the SMA? Do you worry about dissecting the wires in every branch?
No, so we always put a safety wire into the SMA.
Into the SMA.
So
you have multiple wires and two.
Yeah, I mean, to do an aorta in a small baby usually requires both groins and the maxilla.
Right.
Because you have to protect both renals and the SMA.
And the SMA, yeah. Yeah. Wow.
I've seen thromboembolic events related to the dilatation. I've seen dissections. I've seen a silver aneurysm. I've never had a rupture. I've had dissection that we end up putting a stent and the stent occluded. But it was a patient with 4 renal arteries. So we decided to lose that renal artery and we pick up rocolaterals. Eventually, the patient needed to have the kidney removed because of the hypertension. But I think Gulrace made a great point, is that the complications will be similar to what you have in an adult. It's nothing different. But the important thing is to have a plan and to be prepared to deal with the complications. So if you end up with a rupture, to have a balloon prepared or ready to put back and try to occlude. And always we have a backup. The surgical team here is the urology team, who is a backup team for us. We the vascular teams, we also work with them, and it's the adult vascular teams. We don't have a pediatric vascular surgeon, and that makes it a little bit more challenging, especially for us to then embark in dilating aortas. And but I think most of what we do also and is to temporize in the aorta, or to buy time for the child to grow and eventually get final or definitive treatment with a bypass. I don't know what the others think, but that's my gut feeling. And the other thing that's so important to remember is that many of the kids, at least in our, about 50% will need a second dilatation. And we call fibromuscular dysplasia, but we don't really know why these kids have this stenosis. And we've seen patients that progressed from having just renal artery stenosis to later on in life developing new areas of stenosis or mid-aortic syndrome, which we don't really understand yet how or why they have. So the results that from fibromuscular dysplasia for women who that are around 90% of, or not to 95% of good results post-angioplasty, they don't reflect similarly in children. I think the rate of recurrence is higher than what it is in adults. And I think it's a disease process. It's not what we think that it's only just a focal area. And of course, some of the patients will have fibromuscular dysplasia. These are the ones that we are all happy and we present in all conferences that we'll see how great are my results. But the reality is that, and if you look at all the series or the largest series, which are from CHOP, from GOSH, from here in Toronto and other centers, they all show a cure of about 30%, that you're fully cured, but an improvement of about 70%. And a recurrence, it's not low. And you have to be prepared to redilate these children over time. That's my experience.
I would say, Joao, if I can push back a little on the adult and kids, having seen some of the adult work, no disrespect to the adults, but if there is a referral center with an area of expertise, I think that FMD and the need for angioplasty in children should be referred there. Sometimes it's out of network in the States and a bit of a problem for kids, but you can get around that. But there have been some disastrous referrals to Michigan from adult people dilating and attempting to dilate younger children's arteries. So I would say it's a different bird. It's a different platform of devices. You may need, I keep saying the cutting balloon, but I think you do at times. And it's a much different psyche to be treating somebody's renal artery in a kid who's 5 to 10 years of age and not 50 to 60. So
Marie,
yeah.
No, I fully agree with you.
Yeah,
I wasn't talking about the
that,
treatment. Yeah. I truly and fully recommend that get a pediatric interventional or a pediatric hospital to treat. What I meant is the complications.
Yeah.
They are not different in children than it is in adults. They dissect, they rupture, they have to be managed differently, or they have to be treated in a different way, because kids also, when they bleed, they take much less time to exsanguinate and all that, but not really that I'm not advocating that or I'm not saying that. I think really it's a small number of patients that should be treated in excellent centers. No doubt about that.
Can I just say, we know that this is a multifocal and progressive disease in children, and we often see the SMA is involved and or the celiac axis, and we have never treated an SMA.
No.
But, and I guess this comes back to one of the differences, but we have seen many children referred who have had drive-by SMA plasty. And I'd just be interested to hear, your opinion, because as I say, we've never treated it and have never had the need to treat it, in all the time, pre-me, going back to the beginning of Derek's time. And so what I would like to know what Anne-Marie, Gorraiz and Joao do.
I mean, I think the body is an amazing thing. The SMA and the celiac can be out, and the IMA will do all the work, because you can't afford to lose your gut or you'll die. So how often have we ever needed to intervene? The body just knows how to, you know, develop. I can say that to my team all the time. We're amazingly well developed. You can't lose your gut and live. You can lose your kidneys and live. So your kidneys can lose volume and you've got to dilate them so they'll grow. But your gut has 3 ways to get supply: SMA, celiac, and the IMA becomes a hose if your SMA and your celiac is out. So never in 18 years have I had to touch an SMA or a celiac, never. And the patients don't even have abdominal symptoms usually. No. You know, they've compensated. Yeah.
I agree. Yeah. I mean, the other thing that we do here is we actually use the marginal artery, which is significantly enlarged in these patients, as the bypass, which are surgical.
Yeah.
So that actually comes, so, you know, we would never routinely, can't remember ever plasting just the SMA, to be honest, in these patients. And in terms of whether we temporize or go for definitive treatment, it really depends whether the only lesion we can identify is an isolated renal artery, in which case I think endovascular intervention as the final treatment is reasonable. If we, as we see many patients with quite extensive mid-aortic syndrome with celiac, SMA, and bilateral renal artery stenosis, we will sometimes temporize to trying to get to the patient to the size that people are comfortable performing a bypass in. But at any point, if our surgeons feel that they're comfortable performing a bypass, I don't see necessarily the need to perform endovascular interventions prior to that. I mean, they will also, in addition to the bypass, you do have to auto-transplant the kidneys.
Prem, I'm happy to hear that I'm not the only chicken. You know?
Well, no,
I've never dilated an SMA, and I fully agree with Maria. I mean, it recanalizes, it finds its way, and if I'm not really pushed, if there is no other option, yes, I think we can and we should. But if there is a good collateral supply, I think it's questionable if you're gonna help or harm, and that's the main risk. That I think if you have a very good collateral supply, your risk of dissecting or having a thromboembolic event, it's not small, and then I think you could end up with a bigger problem. I would even consider consulting the surgeons and sometimes the transplant surgeons, if they would do a bypass or if they would reimplant the vessel, because I think you carry some risks.
Yeah, and sometimes they do have to implant if the aorta is so crappy at that section and the patient has symptoms. We've seen a couple that have been reimplanted. Yeah, it's uncommon, but they do.
Well, the other thing I would say about potential complications is, in addition to coordinating with other services, I think it's important to also have all the equipment you need to potentially deal with a complication. You know, and so, for example, you may not want a stent, but it's also essential to have a covered stent around just in case you need it. The last thing you want to be doing is searching for things as things are going wrong. Yeah.
And the covered stents, remember, are not approved for renal use. They're cardiac. So you sort of have to get around that humanitarian sort of thing by having them in your cardiology suite. And God forbid you have to grab it, you have to grab it, but they are not approved in the US, I should say. I'm not sure about Europe for anything but cardiac. So it is a humanitarian exception, which is frustrating. For the shorter ones, the 2, 3, 4 millimeter. For the larger ones, 5 to 7, they're adult. That's a different situation. So it is tricky.
Could I jump in there, Dr. Schilling, just to throw out some audience questions? We are at 9 o'clock almost, so I'll do some quick fire questions just on some technical factors. So someone's asked about how do you size ostial stenosis? Can anyone comment on that?
Well, I'll jump in here. I mean, you size it by the arteries a bit further distal to the ostial, not immediately post-ostial. So because then you'll have the post-stenotic dilatation.
Thank you. And someone has also asked, with obviously the much smaller caliber of the aorta, any advice on what's the catheter to use for very small aortas to cannulate the renal arteries? Any specific catheters that you would recommend?
I would say my go-to one is the 4-French Sauce Omni. And if you know it's a very tight stenosis, you go in with the wire that you're going to use for your platform. So let's say it's an 014 system, you go in with the 014 wire. It's not a great match with the catheter, but once you're in, you're going to stay there. And then you put in your appropriate angioplasty balloon or whatever you need. Yeah, it's been my go-to one when it's a steep curve or when it's a very tight stenosis. It really can do a good job with hooking in. It's a small shepherd's crook. Yeah.
Thank you.
So we don't like the reverse curve catheters. This came up in a SPIR discussion recently, and actually, what we tend to use is just a C2, and if we can't get in with a C2, I like to use a steerable microcatheter and use it as a reverse curve.
So you like the Ninja?
Yeah, I used the Swift.
The $2,000 Ninja. Oh my God.
Well, Sam Stewart bought it, so.
I know we have it too, but I doubt I'd be allowed to use it for renal arteries. I'm sticking to my Sauce Omni. It does work. It's a dirty little marriage with the 014 wire, but once you're in.
And as you're pulling it out, do you not end up dottering the
you have to look very closely and be very careful when you're coming out. Yes. Because you can flick the wire into the aorta. Yes. But it comes out.
I'm a simple guy. I like a Bernstein with a small angle and just.
I know, but the Bernstein doesn't go in. I mean, God bless you, but the Bernstein doesn't go into those steeper angles. How do you get in with all of those more vertical ones unless you go through the arm?
Yeah, no, I think that was one of the comments that I was going to make, Anne-Marie.
Yeah.
It all depends. I mean, what people are used to is always what is, it makes it easier for them. That's one of the comments. Yeah. And I find that the Bernstein with a wire, I generally can find my way and then push the wire and make it, because the angle and the aorta is not that large, and it doesn't give me so much space to pull the catheter out.
Right.
But I think you brought a good point, and I think Prem likes sometimes the arm access is better than the groin access, and especially in very, very acute angles, then you should consider that. I'm always for the neurointerventionists use the right or left arm. I would always use the left arm because it avoids crossing the arch. But I think this is something to be considered. And the smallest device that you can put, the best. I think that's what my point is, and what you are used to. But certainly, I find the Sauce Omni is also very good. When I'm not getting with the Bernstein, I get the Sauce Omni or the C2. What I find sometimes with a C1 or C2, they don't form the curve. Because the aorta is too small.
Yeah, and then my go-to is usually a C2 glide cath for French. But you're right, when the aorta is very narrow, it's difficult to form the curve. And then I've even in the past have also used a 3 French Bernstein, and that seems to work as well.
I've got to say, I use the arm a lot, especially in small children.
Thank you.
Yes, which one, Prem? Sorry, which one?
The arm, the left.
Oh, the arm,
yes.
Yeah. The axillary artery, right?
Thank you. And I'll throw in one last question and I'll close the session, which is, do you have a minimum age that you're willing to treat to the panel? No.
Oh.
Okay. Well, we are 5 minutes over 9 o'clock, but we could talk, I'm sure, for easily another hour on this interesting topic. I'm going to have to close the session there, but I want to again thank all the amazing panelists. Thank you all for tuning in from all your different time zones. Thank you so much, Rocky, for your fantastic, comprehensive talk. And Dr. Tuning wouldn't have been able to obviously organize the session without your support and the help of the SPIR. So looking forward to organizing another joint session again in the future. Obviously, feedback is really useful to improve these sessions. I've sent a link in the chat, so please fill out that form, because we will always improve these sessions based on what you want in future talks. And also, we've got an upcoming hiatus, because next month we have SIRC, so we're taking a break from the Journal Club, but we'll be back with a bang in October. And we also have a research and interventional radiology day on the 15th October. Again, the sign up link is in the chat. Dr. Tuning, anything last words from yourself at all before I close the session?
Just thanks again. It's obviously an amazing discussion. Thank you to the panelists. Thank you, Rocky, again. But Jim, thanks again for organizing this. We really enjoyed it, and look forward to an ongoing relationship between our groups.
Brilliant. Okay. I shall close the session there then. Thank you, everyone. Take care. Enjoy the rest of your summer and stay safe.
Bye.
Thank you.
Thank you very much. Bye.
Bye.